Okay, good evening, everybody. My name is Dr. Nick Thomas, and I'm a GP at Whitney in the medical practice in West Oxfordshire. It gives me great pleasure to be here today. I'm also the clinical lead for research at the RCGP, working really closely with some of the amazing people that you're going to hear from tonight. So here we go. Right, it gives me great pleasure to welcome you all to this webinar. This is a launch meeting of the 55th year of surveillance here at the RCGP RSC, and this is in collaboration with Public Health England and the University of Oxford. A couple of housekeeping rules, really. There'll be no voice chat tonight, but if there's a chat function, so if you please have any questions, please feel free to ask them. Write them in the chat. I'll try my best to make sure I get them to the right person to get those answers for us while we're on this webinar this evening. So it's a star-studded lineup that we have tonight. Absolutely unbelievable, and to be able to present this is incredible. So we have Professor Simon de Lusignan, who is the Professor of Primary Care at Oxford. He's also the Clinical Informatics Lead and therefore the Director of the RSC. We all know Simon extremely well, and we look forward to hearing from him slightly later on. We have Margaret Ikpoh. Dr. Ikpoh is GP partner at Holderness Health, and she's the Associate Director of Primary Care Education. Absolutely amazing to have her here too. We've also then got a consultant epidemiologist and Immunisation and Countermeasures Division from Public Health England. That's Dr. Jamie Lopez-Bernal. We've also then got a project lead for Public Health England and real-time syndromic surveillance team, Dr. Alex Elliot. You'll be hearing from all these people shortly. Absolutely incredible. Can't wait. But without further ado, I've got great pleasure in presenting, first of all, Professor Martin Marshall, who is the chair of the RCGP. Over to you, Martin.
Nick, thank you very much indeed. Hi to everybody. As Nick says, I'm Martin Marshall. I'm chair of the college. I'm a GP in East London and also an academic, a health service researcher at UCL. It's a real pleasure to introduce this webinar. The Research Surveillance Centre really is the jewel in the crown of the college's portfolio. We know that the best healthcare systems are underpinned by high quality data systems. We know the NHS has always had an awful lot of data, but we haven't always been able to use it. It's not always been very accessible. It's not always been particularly high quality. So a long way away from being able to achieve its potential to improve care and improve research. But through the Research Surveillance Centre, we're now establishing an ambitious new data hub, which is really going to change things. So as Nick says, the centre was established in 1967, so it's now 55 years old. There's been a massive growth, particularly over the last few years since it moved to Oxford. It's a partnership between the college and the University of Oxford. The growth of practices has been truly enormous, and now we have over 2,000 practices in the network and over 1,000 collecting data on a regular basis. The great strength seems to me to be the bringing together of different purposes and different functions. The core function, disease surveillance, started with flu surveillance, of course, but also surveillance of other infectious diseases, and during the pandemic, surveillance of COVID, of course. But also the database has been used for research trials, trials of COVID treatments, workload surveillance. It's this integrated kind of multi-purpose function of the network that I think makes it so exciting. I have to say, other data systems do exist out there, of course, but the RSC seems to me to have unique strengths. World-class researchers, of course, is fundamentally important. The relationship between those world-class researchers and the professional networks that the college brings, the 54,000 members, the multiple practices that it brings as well. But also, I think, probably most importantly, the closeness of RSC to the front line, to the clinicians and administrative staff that are collecting high quality data on a daily basis, where that data collection is part of business as usual, if you like, and it's very clearly linked to clinical activity. So I'd like to thank you all for joining the webinar. I'm really confident that you'll enjoy it, and I'm hopeful that you'll want to, if you haven't already, join the partnership and help us to build better data systems for the future. So thanks so much. I really hope you enjoy the evening. Back to you, Nick.
Thanks, Martin. I couldn't have said it better myself, and I was never going to say it as well as you, certainly not. I think the big point that you just made is about that professionally led, great leadership by Simon, the RSC, and the way it's certainly transformed through COVID. but also your point with practices and how it reaches out to the practice, getting to the coal face. And that's probably where its strength has developed, hasn't it, over time? And I think that's certainly where we always try to underpin all of the work within the RSC. It comes back to that again, doesn't it, with our strong membership within the college. Is that right?
Yeah, absolutely right. Spot on.
Brilliant. Thanks, Martin. And thank you again for joining us. It's really kind. Amazing. Right.
Pleasure.
So moving on, we have Dr. Alex Elliot, Project Lead for Public Health England. Absolutely fantastic to have him here today. Another informative speech we're going to get, I've no doubt. I look forward to asking many questions at the end of this. So I'm warning him now, unfortunately. But here we go. So Alex, if that's all right, with wider uses of GP surveillance data and syndromic surveillance, obviously this is important. This is the most important bit. It's what we're all talking about. It's why we're here today. And so it's over to you, Dr. Elliot.
Thanks, Nick, and thank you for inviting me this evening to come give you this quick talk. So I'm going to try and give you a feel for, as the title says, some of the wider uses of GP data that we use within Public Health England, and show you some examples of that, and also some of the work that we're currently doing with Simon and his team to hopefully give you a feel for how we're taking this forward. So if I could have the next slide, please. So I think it's always quite useful to start off with some sort of historical context, and I'm sure I don't need to tell you the historical basis that we're sort of talking about today in terms of the weekly return service as it was. And I, in fact, started my career in epidemiology near 20 years ago, working with Douglas Fleming at what was then called the Birmingham Research Unit. But obviously, this has now been taken forward by Simon and his team, initially in Surrey and now Oxford, and really shows a nice evolution of how this, I think this sort of, really is the jewel in the crown of general practice surveillance, how it's been taken forward. And what I'm going to show you now is based on some of the work that we're currently doing with Simon and his team, but also some of the work we've done over the years on our GP surveillance. So next slide, please. So as you're going to hear from the next speaker, I think one of the big focuses around the use of GP surveillance data from the RCGP has been around flu surveillance and other respiratory virus surveillance. And I think for good reason, because I think RCGP flu surveillance really was at the forefront of the expansion of flu surveillance internationally. And I think it is true to say that the RCGP flu system as we know it today really is the gold standard of flu surveillance really across the world. And it started back in the early 1990s when, again, Douglas Fleming worked with colleagues at the then Public Health Laboratory Service to show that you could not only collect clinical data from GP practices, sentinel network across country, but you could actually collect clinical samples as well and link together the clinical and the virological data. And that proved to be a real sort of a starter for something really exciting. But what I'd like to do really is to kind of show you some of the wider uses outside of flu surveillance. The next slide, please. And this really brings me on to some of the sort of wider areas of interest that we have in Public Health England. We talk in Public Health England about having a sort of multi-hazard approach. So whereas we are extremely interested, obviously, in infectious disease surveillance, Public Health England has a lot of other areas that it focuses on in terms of impact on public health. So everything, as I say, from infectious diseases, but not only respiratory, we look at things like gastrointestinal, vaccine, preventable diseases, through to things like environmental impact. So heat waves, and with the advent of climate change, things like that are becoming more and more relevant. Cold weather, flooding, all of these things can impact on human health. And what we want to know in Public Health England is what that impact is and where it's these sorts of incidents are impacting. And also through to things like big chemical fires and air pollution. Next slide, please. And so in Public Health England, my team, which is based in Birmingham, runs a series of national, what we call syndromic surveillance systems. So the only thing I'll say is that these are different to what you would normally see in terms of things like laboratory-based surveillance, where you're looking at confirmed cases of a particular pathogen, for example. What we're looking at here is really that sort of initial presentation to a healthcare service. And so you can see we monitor things like emergency department attendances, calls to 111, and we also monitor both in hours and out of hours GP activity. The key thing about these systems is they look at really quite big data. The data are anonymized, so we're not looking at any sort of patient identifiable data. And one of the key things is this real-time nature. So instead of waiting for a week or maybe weeks or months to actually look at data, we're actually looking at these on a real-time daily basis. And this can give us early warning of potential problems in the community. Next slide, please. And so I talked about this multi-hazard approach. This was very quickly just to give you a sort of a feel for that. So again, on the left, the classic sort of respiratory work that has come out of the RCGP GP Sentinel network, but we also are interested in things like the gastrointestinal, environmental, and other things. And you can see here some examples of some of the sort of the collections of presentations or consultations that we would look at. Next slide, please. So what we do at the moment, in the past, we have had a system that has been based on things like the Q surveillance data set. We currently use data from a network of practices that use the TPP System 1 system. And next, if we could just forward on one, please. And we use those data to essentially monitor these conditions in real time. If you could forward on. So thank you. So now what we're doing is we're exploring with Simon de Lusignan and his team the possibility of using data from this ORCID data hub. And really, it's with the aim of taking what we already do, which is an extremely good GP network across England, but essentially trying to incorporate these additional ORCID practices to boost our numbers across the country. And therefore, that enables us to deliver a better and enhanced local public health service to support some of these events and incidents that I showed you earlier. Next slide, please. And so some of the benefits that we're going to see from this is we'll be able to actually show the use of the ORCID data being used on a daily basis. So at the moment, the data are predominantly used on a weekly basis. It will give us that large population coverage. And what we're able to do is to really enable public health action to come from these ORCID data alongside our other GP data sets. Next slide, please. And so just to give you an example, just in my last few slides, I thought I'd give you some real sort of life examples of where we've used our GP data in the past. And I'm going to take some real sort of ones that maybe you wouldn't expect us to have been responding to, but I don't think everybody can put their hand up and say that they have been involved in the response to a big volcanic eruption, but I can do that, which is I'm always quite proud of. But back in 2010, you may remember there was that volcano in Iceland that erupted, emitting a huge ash cloud across large parts of Western Europe. One of the key sort of public health risk assessments was around exposure of the ash to patients, particularly with underlying chronic conditions. And so we were able to use GP data to actually monitor presentations to GPs to give some reassurance that actually we weren't seeing increases in consultations. Next slide, please. Next on our list of, if you like, sort of unusual incidents that we responded to, just this year, actually, we monitored using a range of our syndromic systems. What you can actually see on the chart here is ED attendances, but we did see this in our GP data as well, with something called thunderstorm asthma. And I don't know whether everybody is aware of this sort of phenomenon, but when we get large thunderstorms occurring in the summer months, particularly when there's high pollen levels, we can get these quite nasty exacerbations of asthma in patients, either with or without existing asthma. And there was a really large episode in Australia a few years ago where there were a significant number of deaths that occurred from one of these thunderstorm asthma storms. And so this is a good example, again, where we can use these systems to monitor the health impact of some of these more unusual events. Next slide, please. we also monitor something called back to school asthma. And this is something that, in fact, has been recognised by the RCGP's GP network for years and years, where in September, when the schools return after the long summer holiday, we tend to see quite large spikes in asthma symptoms in school children. And again, this is something that we've done some work on with our GP data, which is one of the systems that we particularly picked this up on. And some of that work is to try and understand the underlying causes, and also to try and get some public health messaging out there to make sure that patients are aware of controlling their asthma symptoms. And the next slide, please. Just again to bring it up to date, this is a very recent explosion. I don't know whether people recognise this, but this is the big plastics fire explosion in Leamington Spa that just happened last week. And this again is an incident that we were asked to respond to, and you can see again the black smoke plume going up over quite a residential area, and the questions or the risk assessment there was is there a local sort of health impact on patients in that area? And again, using GP data alongside their other systems, we were able to respond to that. And finally, I just thought I'd raise another very important area, which is around mental health surveillance. And this, of course, has been particularly highlighted around the current pandemic. And this is something we're again looking into to see whether we can utilise routinely collected data on mental health presentations in general practice to actually paint a better picture of what's going on, and also in response to certain events such as flooding or maybe sort of terrorist attack, we can actually monitor mental health presentations to try and generate some public health action. So finally, on my last slide, that's what I really wanted to say, but I just wanted to highlight, once again, I'm sure many of you have seen, Public Health England is actually going to be moving into the new UK Health Security Agency on the 1st of October this year, but it's really just to emphasise that a lot of the work you'll hear about tonight between the collaboration of Public Health England and the RCGP and the RSC will, of course, seamlessly move into UK Health Security Agency. And thanks, Nick. That's all I had to say, but I'm happy to answer any questions.
Thank you, Alex. That's absolutely fascinating and absolutely brilliant to listen to. Just Public Health England are they changing their name officially to the UK Health Security Agency? As a question, it's a quick one.
So the UK Health Security Agency is pulling together Public Health England, Test and Trace, and Joint Biosecurity Centre. So it's actually several organisations coming together. But the most of the components of Public Health England are moving into UK Health Security Agency. But it is important to say that other parts of Public Health England will be moving elsewhere.
Okay, brilliant. And I've got a question, if that's all right. One was burning for me. My friend has actually lived in Leamington Spa, so I saw actually a video of that fire, which was just absolutely horrendous. But I guess this is the beauty of the RSC, isn't it? And the relationship with Public Health England and the whole data, and to inform the messages that we see in the press, that we see on social media. It's all of that we get that come back to the public, and our relatives and our friends tell us about. Oh gosh, have you heard about this? What's going on around in Warwickshire that they're watching at the moment? And it's that easy thing that general practice can do to help. It'd be part of the RSC, the data circles through and it comes back through to help inform and engage and really facilitate such the vital work the Public Health England do. So I think that's right, isn't it? That's what you're describing to us today.
That's absolutely right. So essentially what we're doing in my team is we're utilising the data that you as GPs are routinely collecting as part of your routine patient management. And we're almost sort of giving it, using it for the secondary use alongside all of our other systems. And the power of it is that we can actually triangulate what's collected in general practice across other systems. So that gives us much more confidence sometimes in what we're seeing. But I think it's both the looking at the data to see if we can see any impact, such as that Leamington fire, but also one of the big strengths is actually giving messages of reassurance out. And again, that's one thing we did with this fire, is actually we looked in the local area at things like our GP consultation data. We're able to say that we hadn't seen any increases in patients presenting with any of the symptoms we might expect. And that's a very powerful message to give.
Thank you, Alex. That's absolutely fantastic. Any more questions for Alex and any of our speakers, please, can I just obviously navigate everybody again and signpost them to the chat. Please type anything you want from questions on there. Alex will be back later on to answer any more questions that you might have, which is absolutely fantastic again. And thank you, Alex, for your time. Brilliant. Right, moving on. Without further ado, we've got Dr. Jamie Lopez-Bernal, who is a consultant epidemiologist at Public Health England. He's going to talk to us about something that's we're not interested in this, are we? Vaccine effectiveness. Goodness me. If ever there was something that's pretty apt and obviously on the tip of our tongue all of the time, it's this, isn't it? So Jamie, over to you.
Yeah, as Nick said, I'm going to talk about how we monitor vaccine effectiveness in the UK and through the RCGP RSC surveillance system. Given our current situation, I'm going to focus on what we've been doing with COVID-19 and how all of your support as part of the network has allowed us to better understand the COVID-19 vaccines and to inform policy decisions around the vaccine rollout. Next slide. So this just gives an overview of what I'm going to cover. So starting with why and how we monitor vaccine effectiveness. I'll give some examples of the different vaccine effectiveness analyses that we undertake, discuss how the data is used, and then finally give some key messages for practices related to this work. Next slide. So why do we monitor vaccine effectiveness? You'll all be aware that all of the vaccines underwent phase 1, 2, and 3 clinical trials, the latter which focused on vaccine efficacy. So why do we bother with these additional real-world studies? So I'll start by highlighting some of the data that we started to see emerging from clinical trials around November and December last year, and that we continue to see emerging for some of the vaccines. So the primary endpoint of the clinical trials is laboratory confirmed symptomatic disease almost universally. They also typically have secondary endpoints that focus on things like the impact on more severe disease, such as hospitalizations and deaths, although they don't tend to be all that informative about those outcomes due to the sort of limitations with the numbers that they can recruit into the trials. Some of the trials, for example, the AstraZeneca vaccine trial, also use serology to look at efficacy against infection rather than just symptomatic disease. But the majority, as I say, are focused specifically on symptomatic disease. And the follow-up that we have seen from the trials generally tells us about short-term efficacy. Certainly the data that was presented early on early on just before the vaccination program started was only around sort of 2 months follow-up with the interim analyses that were used for the regulatory purposes. The trials are planned for 12 months or were planned for 12 months. The issue, though, has been that many countries have obviously well into their rollout of the vaccination program now, at the same time that trials were ongoing. So that's obviously contaminated both the intervention group and the control group of the original clinical trials, which has limited the amount of follow-up that can be used for them. The study populations within trials have relatively broad age groups. They're generally divided into 2 categories, younger and older adults. And there have more recently been trials of vaccines in children as well. Some exclude those that have been previously seropositive or have a recorded history of previous infection. And in others, they are included within other sub-analyses. And also those with certain medical conditions are typically excluded, though they often do include participants with mild or moderate well-controlled comorbidities. And the majority of participants within trials will receive a full course of vaccine at a very clearly defined interval. So what are the questions that haven't been answered by the clinical trials. Firstly, we want to know what the real-world effectiveness is of a vaccine in a representative population, including those with comorbidities, history of past infection, and not restricted to individuals that are willing and able to take part of trials. Also, there may be differences in the real-world situation where there might be things like imperfect storage of vaccines, imperfect delivery, and cold chain issues. And that's particularly an issue with vaccines where there have been logistical challenges. So you may well recall that with the Pfizer vaccine, when it was first introduced, there was this requirement around having it at very cold temperatures that standard freezers can't use, and also in very large packages, so that it wasn't a simple vaccine to use, for example, in a care home or in a home visit. So that all of those factors could impact on the way the vaccine gets delivered and could impact on the effectiveness in the real world. We also often want to know effectiveness in specific groups that might not be included in the trial. So I've given some examples here, such as older adults, in particular individuals with comorbidities. One of those that we're particularly interested in is immunocompromised groups. And then also children, pregnant women, and certain occupational cohorts such as healthcare workers. So the trials don't tend to have the numbers to be able to disaggregate within those groups. It's important also to understand the impact on different outcomes such as severe disease, also the impact on infection, and on transmission. All of these factors will inform policy decisions around who gets targeted with the vaccines and in what order, and which particular vaccine we decide to use. For all of the outcomes, we need to know how long the protection lasts to inform any decisions around the need for booster doses. And also, as you'll be aware, within the UK, we focused on maximising coverage of the first dose. Most of the clinical trials are focused on vaccine effectiveness with a full course, which is typically 2 doses. But because of the way the rollout started in the UK, it was really important for us to have early information on how effective a single dose of vaccine is. Also having studies within the real world just tends to help with comparative effectiveness of one vaccine to another vaccine, given that they're all being evaluated within a single study. Finally, there are also questions around things like the use of vaccines as post-exposure prophylaxis within a specific outbreak. Great. So how do we monitor vaccine effectiveness in the real world? So I outlined some of the different questions that we can answer using real world studies. However, they are very different to clinical trials. We almost always use observational study designs to evaluate vaccine effectiveness after a vaccine's been introduced. And this means that there's a whole range of potential biases related to the way that the program has been rolled out, to differences in vaccinated and unvaccinated populations, or in populations receiving different vaccines. And all of that can make the results of some of these studies difficult to interpret. We can use routine data for these studies, and one of the greatest developments that has occurred during the pandemic is that we've got national level data on positive and negative test results, and there's obviously a huge amount of testing going on. There's also whole genome sequencing for a big proportion of samples, and we also have a national vaccine register, which is something that we've never had before. The RCGP in particular has hugely expanded over the course of the pandemic, and this obviously enhances our ability to estimate vaccine effectiveness within specific groups. So PHE and several academic groups have used studies. In addition to the routine data, we've also used studies with detailed follow-up, such as you may have heard of the Siren study, the ONS Community Infection Survey, and the Vivaldi study. And this allows more detailed follow-up with patient interviews and repeated contacts to find out about ultimate outcomes of their illness. In terms of the study designs used, there are two main approaches that people have been using to monitor vaccine effectiveness with COVID. Firstly, cohort studies, whereby we start with a group of vaccinated and unvaccinated individuals. That status obviously may change over time. We then follow them up to see whether they've developed COVID and also to look at other outcomes of their illness, such as whether they've been hospitalized. One of the issues with this sort of design is that vaccinated and unvaccinated groups may differ in terms of their behavior. So vaccinated people may have better access to healthcare or may be more motivated to access healthcare and therefore may be more likely to get tested for COVID. And if you're getting tested for COVID, you're more likely to have a positive result. Whereas if the unvaccinated group are less likely to get tested, even if they have symptoms, we don't find out about that. And that can artificially increase the number of cases in vaccinated groups and therefore reduce the apparent vaccine effectiveness. Another approach that we use, therefore, is the test negative case control design. And there you start with cases and you compare vaccination rates in those cases to individuals who have tested negative. So we know that they've all both the intervention group, or both our cases and our control group, have presented for a test. So we know that they're accessing healthcare, and that helps to control for some of these differences in health-seeking behaviour. But there are other issues, again, with case control studies, in particular around misclassification. All of the tests that are used to detect COVID, including PCR testing, do have a level of sensitivity and specificity whereby you can get misclassification with false negatives and false positives. So moving on to some examples. One of the key questions on vaccine effectiveness is what happens when new variants emerge. So different variants obviously may be better at evading vaccines. And this is something that came up with the emergence of the Delta variant back in May. We've now got a high proportion of samples that are sequenced in the UK, including all of the samples that come through the RCGP collection. And this meant that we were very rapidly able to evaluate the impact of the new variant on vaccine effectiveness. In this figure here, you can see that the y-axis gives vaccine effectiveness. On the x-axis, we've got the different vaccines. So any vaccine to begin with, the BNT vaccine is the Pfizer vaccine, and Chadox is the AstraZeneca vaccine. And then we divide by dose. So the figures on the left are dose 1 data, and the right dose 2. And you can see that overall there is around 50% vaccine effectiveness with the Alpha variant in the blue with dose 1, and around 30% with the Delta variant, with the drop being most notable with the AstraZeneca vaccine. However, after dose 2, there's much less of a difference. So that obviously went into informing all the sort of SPI-M modelling and the policy decisions around vaccination after the emergence of the Delta variant. Also, by linking to hospitalizations and deaths, we can look at how these outcomes have been affected by the Delta variant. And actually, we've seen the vaccine effectiveness against those more severe endpoints is very similar between the Alpha and Delta variant. So another example whereby we've used RCGP data and with all of your help collecting samples from patients who are presenting for other routine blood samples, we've been collecting some extra samples to look at serology And this allows us to gives us an idea of both the number of individuals who've been infected in the population and has been used throughout the pandemic for that purpose. So what we call seroprevalence monitoring, but also to monitor the immune response to vaccines. So one of the great features of the RCGP network is that we've got very detailed clinical data on past medical history, so we can identify clinical risk groups that may have different responses to vaccination. And this has been really important recently in deciding whether any groups need additional doses beyond the standard 2-dose course. So here you can see the proportion who develop an immune response to the first dose of the vaccine. At the top, you can see that people in a clinical risk group have a very slightly reduced chance of becoming antibody positive after dose 1. So the prevalence ratio there is 0.95. That indicates a 5% reduction in the likelihood of being S antibody positive. So that's the spike antibody of the coronavirus. And then the shielding group, just below that, we see a further reduction in the proportion that are develop that immune response after the first dose. Then we break it down into specific risk groups, and it looks slightly lower in those with diabetes, but in particular, there's a notable reduction, 25% lower in the immunocompromised group. Next slide. So here we see the post-dose 2 responses by risk group. Interestingly here, there were only 5 individuals in the whole cohort who didn't respond, so weren't S antibody positive according to the test thresholds after a second dose. So that obviously that's really good news, but it does mean that we can't really say much about the impact of different risk groups on S antibody positivity after a second dose. Instead, what we've done is look at the levels of antibodies, so the titers, and this is expressed as a geometric mean ratio on the right of the table. And we can see that there are lower titers in those with chronic respiratory disease and also in the immunosuppressed group. Obviously, these are very broad groups at the moment and will include anything ranging from very mild immunosuppression to those with much more severe immunosuppression, such as post an organ transplant. But it does give you a good indication of what the immune response is like in these broader groups. One thing it doesn't tell us, though, is how that correlates with clinical disease and certainly against severe disease. And you can see, as I mentioned, that despite the lower titers, a vast majority are still seropositive, even in those risk groups. This is just to highlight that the respiratory samples that you send through are being used to look at the impact on clinical disease. So here again, you can see the different risk groups and what the impact is on cases turning up to general practice with respiratory conditions that you've reported to us. And you can again see an impact on immunosuppression. But on the next slide, you can see that after a second dose, that impact is much less. I think maybe if you just show the next couple of slides, but I probably don't need to go over them. I think I've outlined how the data will be used, and just a key message is obviously a big thank you for sending all of these samples and all of the data, and just encourage you to keep sending them and ensure that we're getting good recording of symptoms and vaccination status. Thanks.
Well, thank you, Jamie. That was fantastic, and I think I could ask you questions for hours, to be honest, but I won't. But just comment on that, Ray. That's the big thing, as Jamie just said at the end, then, which is actually about what the practice is role and what's the GP's role. What are we doing? It's two-pronged, really. One is the surveillance, the swabbing, the serology, really important. The other side of that then is the coding, the actual data, because then they can interpret the data, look at it, and then perform all the work that they've been doing. So absolutely fantastic. So thank you again, Jamie. Amy. That's great. No doubt there'll be more questions coming through. Lots are coming through, so hopefully we'll get some of those in the end. And without further ado, it brings me on to Dr. Ikpoh, which is wonderful. Margaret, a GP up in Holderness Health. I know Margaret through social media and through the college. Very big presence, Margaret, and wonderful to have you. And thank you ever so much for joining us. Over to you.
Thank you for the introduction, Nick, and thank you to Simon and the team for having me here today. So as Nick has said, I'm Margaret. I'm a GP in Kingston upon Hull. I'll give it its full title if that's okay. Some of you might actually remember the first cases we had of COVID in the country were reported or documented in York, and one of those patients was transferred over to our city at the time, and like most of us, it was a very unknown and very, very scary time. So what I'm going to try and do, I'll just detail part of my interest. So I'm the research lead for Holderness Health, which is a newly formed practice. We were previously 12,000 patients. I'm in the Market Town area. And now we've merged really to ensure our survival with two other practices. So our practice population size is 36,000 patients. And that encompasses quite a degree of the coast. And some of you may be aware of coastal cities and the deprivation that occurs in those areas. If you have time, our CMO, Chris Whitty, has written a really interesting report on the deprivation in coastal cities, and the Hull actually features in that paper. I've got many hats: an appraiser trainer and an associate director of Hull York Medical School, and believe it or not, some of those roles have evolved, I'll explain later, out of flu surveillance, and you'll wonder why. But if you can bring up the next slide, please. Okay, so what I'm going to do is just detail our journey, if that's okay. And then I've only got 8 slides, so it won't be long. And I'll talk about how our journey led to the studies that we're currently doing, and talk a little bit about some of the challenges that we've faced in our practice, and some of the tips and tricks that we use to try and overcome those challenges. So if we can go to the next slide, please. So really, about 10 years ago was when we started. We had a really dynamic appraiser called Nick Summerton, and he used to go on about research all the time. And I wasn't particularly interested, I'll confess, because I thought research is boring, I don't have time to do it, I've got lots of patients and I don't see where it fits with what we need to do. And some of you, if you're as old as I am, you'll remember there was a section in your appraisal that you had to fill out for, how you contributed to research. So after our final appraisal, he gave me a leaflet on how to become research ready, and that essentially is, if you're not familiar with research ready, if you go to approach one of the practice liaison officers like Elizabeth or Carol, they can signpost you there. It's a really useful tool to get started, because it accredits you and tells you what you need to have in place to conduct research on site. So one of the very first things we did was the flu surveillance. And the key that we do now, I mean, I know we're swabbing now, there is no season, it's every day now, but we start early. So whenever you have your flu meetings, we made an agenda item so people were conscious that, here, Margaret's here again, we're going to have to start swabbing people who meet the criteria. We advertised it in any forum we could, whether that was in a practice newsletter, on our website, clinical team meetings, and on social media. And I'm conscious that I feel that we're busier now in practice than I can remember. I've been practicing for about 16, 17 years now. The last thing you want is someone waving a swab in your face when you're on call. But these are the chances, because our face-to-face contact is limited to the afternoon sessions now, because telephone triage has formed quite a dominant area in what we do day to day. It's imperative now that we do try and alert people when we do need them to swab, provide regular updates, and if the worst comes to worst, we've done this before, we've offered competitions in-house, who's the top swabber of the month. I'm not ashamed to say that, with a bottle of whatever, or an Amazon voucher, if that's what suits. Next slide, please. So these are a couple of our studies that we do for the RSC. And I mentioned earlier that we were a single practice before, and we merged. And so now I have about 20 partners. And it did feel just before the pandemic that I had to start again, because I'm having to now convince a wider group as to why research is so important. And I think the pivotal moment for us probably came around March last year, when we had the first patient admitted to Castle Hill here in our local hospital. And we were probably the only practice at the time that had the capability to also swab for COVID. And I remember our PLO at the time, Manna, said to us, we got permission to go into the care homes, because what we were seeing in Spain and Italy was quite scary. And having the capability to go into care homes and swab patients who were vulnerable and at risk and symptomatic really allowed those care homes and care home managers to manage their staff and manage their patients accordingly. And we were also given permission to swab any symptomatic staff on site. And I can't tell you how valuable that was. I mean, we were the envy of the city, because we were able to deal with any people very early on. Self-isolators would be able to work from home. So there was lots of really good stuff that came out of that. I'll move on to the next slide, please. So the challenges that we've faced, there's many. I think the biggest one for us has been the remote consultations. We are still seeing patients, I must stress that, but we're conscious now that we're doing a lot more things remotely, but there have been adaptations. So we're consenting now patients remotely for various studies. Even the swabbing now, has been outsourced to a company, Take a Test UK. So patients are texted, people who meet the criteria, we send them a text via AccuRx or whichever system you have in place, and they're sent a voucher where they can go to the website and they're able to self-swab themselves at home. And so that's been really a game changer for us. Patient and staff anxiety has been a big thing for us, particularly in the last year with all the uncertainties. But having things in place and policies in place now, I think, and being able to swab and test early, I think it's allayed a lot of that anxiety that we've had. Patients who present beyond the period where we can swab them, that's been quite a challenge. But hopefully we've been able to overcome that by advertising widely, which I'll talk about a little bit in the next couple of slides. And of course, the increased workload. I mean, I know I'm bringing it up again and again and again, but it is what it is. And I think for me, the key that's worked is making sure whatever you do in practice, it doesn't become an additional burden. So for example, in the morning before the doctors who are seeing patients face-to-face, the team will go out to each clinician's room and leave a number of vials on their tables for them to swab for any symptomatic or eligible patients that morning. And all the clinician has to do is just label the specimen sample, and then the research team just fill all the paperwork and upload all the necessary forms onto our clinical platform, which is EMIS. So really, we're taking a lot of the stress away from the attending clinician. Of course, you'll know not being able to do routine blood tests now because the blood shortage, bottle shortage has not helped in particular. But again, we've been able to overcome that by seeking permission to do some samples, but speaking to patients and saying to them, we can do a routine sample, but it just feels kind of odd, but we can either delay it till when we can start doing routine samples when we get the go-ahead from NHS England, or if you want to provide an additional sample for serology studies, you're more than welcome to come now. So that's how we've kind of got around that. Can we have the next slide, please? Because I just wanted to say a little bit on data that's been raised. So you'll all be familiar with Simon's motto, coding is caring. I think they're tired of me saying it in practice, but it's the truth. Dr. Mason, who's our clinical director for our PCN, she's equally passionate about coding, and she's given me permission to share this slide. And this is what we kind of circulate and remind people, particularly when you've got such a high turnover of clinicians. We have 11 registrars, an untold number of ACPs in practice. So it's really important to keep the messaging consistent and reinforce why coding is so important. And in fact, our registrars have benefited from the RSC and from ORCID by using some of the quality improvement projects on there and using that for their own education. And I should have declared actually before that I'm not an academic. I just have an interest in academia. Things like thunderstorm and back to school asthma, I've never heard of those before. So I've documented those for a clinical meeting tomorrow. But yeah, so next slide, please, because I can see Nick's reappeared. I need to give me the push. So these are our potential solutions. it's a whole practice approach. That's where I'm coming from, really. Have a virtual PPG group, as we do, because that's really useful and important. Engage your local network, your clinical research network, because they will have some agile team members who are funded. You don't have to pay for them to come in and help you conduct the research. So thank you very much for having me, and thank you particularly to Elizabeth, Carol and Georgina, who've been working tirelessly behind the scenes to deliver this webinar for you today.
Margaret, thank you so much. This is a really important screen that we've got up just now. That was absolutely fascinating stuff. And you're right, it's easy to join the RSC. It's very straightforward. There's really good support with the PLO team. There's really a good support team around them. Joining the engaging with the CRN locally is really important. Research is not boring. Absolutely not. It's absolutely brilliant. I'm not an academic GP. I'm a jobbing GP. And that's what I love it, absolutely thrive on it. And delivering trials, being able to support research and support the RSC and support Public Health England and all the work that we do is vital. And that's why we're here, isn't it? To help our patients at all times as much as possible and help the NHS to develop and grow and evolve and learn from what's happened before. Absolutely fantastic. Thank you, Margaret. Great tips, by the way. Although I don't think my receptionist might be keen on the bottle of something for swabbing and things. I think I'll maybe hold back on that one. Right, Margaret. Thank you so much again. Moving swiftly on, we have obviously our clinical director of the RSC. Absolutely wonderful to have him. Over to you, Simon. If that's right, Professor Simon de Lusignan. Over to you, Simon.
Good evening, everybody, and thank you very much for coming. I won't commit the cardinal sin of going on too long, and we'll aim to finish on time. I planned anyway just to summarise, and let's hope that Georgina's computer will keep up with me as I whiz on to the next slide. So the aim of this meeting has been to try and set up a formal launch of our 55th season. We have, as I think you've come across, this unique collaboration. We've started to use this ORCID name to describe Oxford Royal College of GPs, because that plus Research and Surveillance Centre is such a lot of words to say. We went into the pandemic with around 500 to 600 practices signed up. We've come out of it with, or we got to this stage, should I say, with 2,000. And we also get strong support from the GP computerized medical record system people, EMIS, etc. Our 55th year will be like our 54th. It's all year round surveillance. Historically, it was through the flu season. And it's going to be fascinating to see what happens. If you look at our weekly reports, you'll see we're seeing RSV, respiratory syncytial virus, at the wrong time of year. And who knows what will come through this winter season. So I think it is really quite exciting. And the key contributions of our network members are sharing data. As has already been said, data quality, data quality, data quality. And for the things that Jamie does, we need good data about acute respiratory infections and vaccine exposure. And for everything we do, we need sampling. These virology swabs that Margaret's explained very well, how she's incorporated into practice workflow, as well as we ask patients to give one extra blood sample when they come for a blood test anyway, which we use for serology. May I move on, please? I'd like to say that I see the future of data sharing being bottom-up and professionally led by the ourselves as a primary care community. And I very much consider the RSC to be a network, not just a database. And that we've got some important contributions to say. When people are with me, I remind them that coding is caring, as already has been said. And when I don't think they're listening, I say bad informatics kills, because it's not so much in the area that we're describing tonight, but if you don't know why someone's on their anticoagulant, is it a DVT, a PE, a recurrent DVT, you don't know when to stop and they're at risk. And with our DMARDs and other medicines, again, if you're not sure of the indication, when you stop your methotrexate is rather different if you've got psoriasis from if you've got SLE. And the relationship we are proud of within our practices is that practices share data for SQUIRE purposes. That's for surveillance, quality improvement, research and education. I will whiz on, please. Can I have the next slide, please? Sampling is absolutely key. The key messages are within 10 days of symptom onset. I'm sorry, we've changed it from year to year, but for the next year, it's 10 days of symptom onset. People who give a bottle of extra blood for monitoring antibodies don't get results, whereas if you get a swab for virology, you do. And completing the forms well, like everything else, is really important. A unique identifier to identify the patient, the onset of symptoms, because that's so important, and capturing any vaccine data that's not in the GP system. So someone's been vaccinated against flu in the foyer of their hospital by their chief executive, then it might not have got into their EMIS records, so please add it. And there's a link in the presentation to a comprehensive set of guidance for the coming surveillance year. I'll whiz on, please. I'm just going to skim past that, but I put this in if people are interested in links to the legal basis for surveillance, which we do under Regulation 3, which is in fact the same regulation that the COPI notice that's been much more famous through the pandemic is used. I'll whiz on again. We hope we're here as a community to support. I've left in a couple of websites, the ORCID website in Oxford and the college website. In the background, you can see the characteristic weekly return that has been going weekly since 1967, never missed a week, very traditional and on paper. And I've superimposed on it this year's COVID. The red line is how it's sort of gone up and wavered. And then below it is one of our interactive dashboards where you can pick a region, a year, an age band, and so on, and look at things. We also provide our interactive practice dashboards. Margaret mentioned PLOs. This is nothing unfortunate from Palestine, but rather practice liaison officers who are very much here to help, and two of our team are on the call. I can whiz to my last slide and thank you, anyone on the conference who's a member, your practice, your patients who have contributed, and we still intend to expand. New members are very welcome. We're keen in the coming year to connect as far as we can with patient participation groups or provide practices with materials for those. And we're looking to extend our sampling analytic capacity. We've got a large 3-year gastroenteritis IID3 starting shortly. And the picture bottom right, just in case you don't recognize me, is me having my flu jab yesterday. I put in the background on the screen today's weekly report. And if you haven't, please have a flu jab. And perhaps part of the part of the ethos of the network is we're first in the queue to have these things ourselves. Thank you very much.
Thank you, Simon. That's absolutely fantastic, and I could listen to Simon talk all evening as well. Absolutely wonderful it is. Quickly, Simon, I thought I'd just bring you back in again, if that's all right, about the liaisons with the PLO team, as you've mentioned. The important thing with the RSC I always find is that the engagement at practice level is that feedback with the workforce, the observatories, as you've said, and all the work that you do. We're planning more webinars, is that right, going forward?
Yes, we'd be very keen to have, and again, please can people give some feedback if it would be useful. We have Public Health England experts, we've got experts within the college and the university, and both generically either about virology or if people are interested in RSV, we're happy to put things on, and if there are any requests, that would be very, very helpful.
Perfect, Simon. Thank you so much again. So it's very easy to join the ORCID and the RSC. The responses are really good. It's very easy as well to be part of the surveillance, the swabbing. Really, the beauty of research is you can do as little as you want or as much as you want. Really, really important to stress that, particularly at the time when general practice, I'm here in my practice, still been going on at the moment. I've been having had a great day as usual. And so we all know what it's like right now, but it's really important that we still continue to do this vital work going forward. forward. Right. So without further ado, it's run a little bit late, so I apologize for that. But thank you all for joining us. It's been a great pleasure in chairing this session today. I'd like to thank all the panelists for giving us amazing, informative speeches today, particularly as I'll be using some of those for my appraisal in a couple of weeks' time as well. Absolutely fascinating stuff. Get in touch with the PLO, get in touch with the RCGP team. It's absolutely fine, the research programs here. And I'd wish you all a very good evening. Thank you. Bye now.